helpful.
All right, because that way I know you guys were here. So what I'll do with you guys today is, well, we did the tachycardias, we did have normal conduction work, we did sort of the tachycardias, and then today we can do sort of the bradycardias.
I just have one question based on watching the one from the other day.
Yep.
So like the VTAC, you know, like we're on in the middle of the night and some nurse calls, the monitor called them and they had, you know, a so many beat run of VTAC.
Yep.
And then they broke and were fine. Is that something you have to do anything with?
No, so it depends. So I guess it depends on if it's just a couple beats or if it was something true. We consider sustained over 30 seconds.
Right.
So if it's 30 seconds a beat, that's long. Like we don't see that very often, even on like E4.
Yeah.
So that would require to make sure nothing crazy has gone on with the patient. They're feeling okay. A little run of like 7 to 8 beats here and there. I think I mentioned last time, the easiest thing was just to make sure they're MAG and they're K. Are like, okay.
Okay.
You know, don't forget, it drives us nuts too, because verbally on the telemetry floor, VT keeps the company of sick hearts. So if you have a patient there that has a defibrillator, they have one in because, God forbid, that VT ever comes and it stays, it's going to save their life. So we have patients that we're seeing all the time in our service that have an EF of 15%, and they'll call us like, oh, you just had a 6-beat run of VT. I'm like, the guy's got a defibrillator for a reason. Like, it keeps the company of sick hearts.
Yeah.
So if it's just a couple runs, 6, 7 beats, not necessarily. If you really were concerned about them, or you know, or they started having more frequent runs, and you know, they have nothing else, you know, acutely that like they're not acutely hypoxic, their electrolytes are okay. A beta blocker like metoprolol is an excellent sort of first-line antiarrhythmic drug for stuff like that. So even if you had to call somebody or you thought it was going down that route of being a little bit more acute, you know, 2.5 or 5 of IV metoprolol or 25, it settles the heart down very, very nicely. It's part of the reason we give it in the setting of an acute MI.
Even if they've already broken?
Even if they've already broken, it'll keep it from coming back.
Okay.
So that's why we give it a lot in the setting of an acute MI, because it works as an antiarrhythmic that way.
Schedule it or just give them one more?
So people that are coming with an acute MI, we usually try to give metoprolol like in the acute setting, whether they sort of need it or not.
But this guy just has a couple runs.
I think it's patient by patient. I wouldn't ignore it, but I want to be like, you don't have to go waking up everybody at 3 in the morning.
You know, that's just want to be, I don't want to bother anybody.
Yeah, no, but don't ever think that. It's just more, you know, the reason I say it's patient by patient, if it's a 48-year-old who has no cardiac history, and all of a sudden is having runs of VT, then it certainly would warrant most likely the next morning an echo to see what his LV function is.
Sure.
And then obviously just, you know, I would check his electrolytes.
Tropes and all that. Is that
I don't know about tropes. I mean, you could, but you know, if they're not having active chest pain, it may not get you very far. The thing is, the reason we put defibrillators in, for whatever reason, the cutoff seems to be about an ejection fraction of 30%. Okay. So if someone's EF is, and this is more in the long-term chronic outpatient setting, like I'll have patients that come to me for palpitations, and then we put them on like a 30-day vent monitor to see what they're complaining about, and they'll have little, you know, 3 or 4 beat runs of VT, like PVCs, but if their EF is completely normal and they have no active ischemia, they got a normal stress test, that automatically puts them into like a benign category. Nothing bad should come of that. Now, if they have VT and all of a sudden we do an echo, their EF's 30% or lower, then we know that's a marker that they could have a prolonged arrhythmia and leads to sudden death. That's why people get implantable defibrillators and all that kind of thing.
Right, so like 3 in the morning, guy's just hanging out. He's had 3 MIs in the past. He has heart scarring.
Right, and if he has like a 6 or 7 beat run, I would say if he's not on metoprolol, give him a dose of metoprolol. That will get you through the evening.
Okay, lights are good.
Right, and that could be a daytime or even a daytime discussion with who knows him best. Yeah.
Okay.
Now, if he's having runs or certainly 20, 30 seconds of it, that's a different story.
Yeah.
That's when you'd have to consider using like amiodarone and all that stuff. Hey, how are you?
Good, how are you?
All right. Yeah, so that kind of stuff, but it's not I know we take for granted that we see it. So, but that's the biggest thing. Would you expect to see it? I think in the patient would be the biggest thing, and then if they have a couple runs, they're on a monitor. They're not going to be ignored. You'd want them on telly and all that kind of stuff.
Okay.
It's the only way you'd see it anyway, most likely. All right. So, I don't know, I know you weren't here on whenever I thought today was Thursday, but it's Wednesday. It's like, you can't even tell the difference anymore. I don't know if you had a chance to look at some of the other stuff I put online here and there.
Briefly.
Yeah, that's fine. Just, I know it, so some people may be a little bit different. I'm not going to talk about that so much today, but it is on there. We're going to focus on the bradycardias today, which are sort of a completely sort of separate. When you're looking at the conduction that we spoke about last time, how the heart's wired and how it works, I talked about the entrance ramp, the highways, and all that stuff. That really helps decipher the tachycardias. The bradycardias are sort of their own separate thing. The biggest take-home rule, and I sort of briefly mentioned this last time, is when it comes to bradycardias and cardiac conduction and all that kind of stuff, it can be a little bit difficult to figure out what rhythm they're in. But the thing we have to remember is the heart does have backup generators. So it's always, the heart's usually going to listen to the fastest conductor at a time. So that's why when someone flips an AFib, the SA node gets kicked out of the way, or someone goes into VT, you can't see the P waves anymore because it's listening to the ventricle at that point. If things start to get slow, the sinus node, where P waves usually come from, is usually the fastest on a day-to-day basis, minute-to-minute basis, the fastest conducting tissue in the heart, and that's why the heart listens to that. But the AV node is always trying to pace the heart, and the ventricle is always trying to pace the heart. It's just being drowned out by what's coming down the normal conduction system. The sinus node usually works, we talked last time, 60 to 100 beats per minute, give or take. That's what normal sinus rhythm would be. If the sinus node does not work, the next fastest thing that would kick in would be the node, or the AV node, or the junction. So sometimes you'll hear us use this term junctional escape rhythm. So if your P waves aren't there and the heart wants to keep going, something's got to kick in. And the junction, or the AV node, can beat the heart, and it's usually about 40 to 60 beats per minute. So it's still going to go down those Purkinje fibers, so it's going to be a narrow rhythm. And 40 to 60 beats per minute, you may not feel wonderful, but it's very, very rarely like an acutely, oh my God, this guy needs pacer pads, IV, the whole thing. It tends to be, these escape rhythms tend to be pretty stable rhythms. Not that you'd want to live in them forever, but it's very rare that a junctional escape crumps like on you in 5 minutes or anything like that. The one you got to be concerned about is, and we talked about this last time, the reason I went through the whole electricity thing is we can start to see markers of disease in multiple levels of the conduction system. If your SA node, your P waves aren't there, and your junction doesn't kick in, the only last thing you got is the ventricle. And there is a ventricular escape rhythm where there's a big pause, and then the ventricle just sort of is your last ditch generator. And that's obviously going to be wide because it's coming from the bottom of the heart. They look like PVCs, but they're coming at like only 20 to 40 beats per minute. Those are the patients, while they still may be hemodynamically stable, that would be someone that you would definitely want to let somebody know what was going on because they have nothing left. God forbid that goes away, they're gonna go asystolic. I think you and I have dealt with bradycardia in the ER before. Like when they're in that, you really should have something else going in as far as, you know, get the transcutaneous pads on. I don't know if any of you guys have ever had to transcutaneously pace somebody. It is not pretty and it's not overly effective. There's a lot of impedance between those stickers and where you have to get to the heart, and you have to really crank up the electricity. And when you're cranking up the electricity at like 70 beats per minute, you watch their entire body twitch between the stickers and the heart. You know, their head, I mean, everything goes. We're always taught as fellows that you don't go to bed on one of those things. If you have a patient that's heading towards needing transcutaneous pacers, that's really just a bridge because the transvenous pacer is very stable. Once you actually get it in, it sits in the right ventricle. That's where the pacemaker wire goes through the veins. It's very trabeculated there, so the wire gets caught in there, and you put up the balloon, and it doesn't go anywhere. So it's much more stable. So everyone, you guys should definitely call, obviously, cardiology if anything like that's going on. So, like we sort of spoke last time, the sinus node can be a little bit slow, where it's just beating at like 50 beats per minute, but the rest of the conduction looks okay. So you can, if you have like a competitive athlete, any one of us at our age should be perfectly fine. When we sleep at night, if you put us on the monitor, our heart rate's gonna be 50, 40 beats per minute. It's just gonna drop down. You guys see it in the sleep apnea people with that real high vagal tone. They start doing that, their heart rate drops to 20 or 30, but it's fast enough for the heart to still do its thing. The P waves may be coming out at a slow rate, but once they go, your PR interval may be normal, the QRS will be normal, so it's just, you just know you have some slowing at the node. And don't forget, the AV node and the SA node, where the P waves come from and where the AV delay comes from, that's really where the innervation in the heart is. So that's where people, when we give meds, those are the two places they typically work. That's why when we give beta blockers, like we spoke last time, calcium channel blockers like diltiazem, digoxin, to like slow AFib down, we're slowing down the AV node, so things can't get through there quite as much to keep the heart racing. So that's where all this stuff is coming from. So when we actually get to the heart blocks, sort of like the rule of thumb that we talked about last time, the lower down in the heart you are, the more dangerous things tend to be. So things that come from higher in the heart tend to be more benign. Things that are lower in the heart, closer to the ventricle, are a little bit more dangerous. So you guys probably have had some experience with this, at least with ACLS at least. So there's three types of heart block. There's first degree, second degree, and third degree. First degree tends to be the most benign. Third degree obviously is complete, and then we'll go through some of these. So what's the definition of first degree heart block? You guys know? Very good. Greater than 0.2. So normal is a normal PR interval is one of the one big box, which comes out to 200 milliseconds or 0.2 seconds. And a first degree AV block is that it's just taking a little bit longer for the cars to get on the highway. You get a P wave, it's got to get on the entrance ramp through that AV node and then go down to the Purkinje fibers. You just have a little bit of a delay coming onto the highway. Do you actually drop any beats in first degree AV block? No. So you get it's really just a prolonged PR interval. And based on what we learned last time of where the PR interval represents on the EKG, if you had to put a pin in the heart for someone with a first degree AV block, where do you think the disease would be, or where would the problem be? What do we say represents the PR interval? What part of the heart? What is it? We had the P wave coming from the top, and then the PR interval, and then the QRS. So where is that PR interval? What does that represent? AV node, right? So it's usually a marker of disease or something going on in the AV node. It's just taking longer from the beat to get from the top to the bottom, and there's only one place to do that, and that's through the AV node. So we typically see that with age. The conduction system starts to wear out a little bit with age. In and of itself, it's a benign phenomenon. If the patient's not really dropping any beats, they just have a first degree AV block, it's very rare that it causes true symptoms. As someone who treats it for a living, what it tells me is if I have like an 85-year-old guy who's not on any medications and I do his baseline EKG in the office and he's in sinus rhythm with a first degree AV block, it just lets me know his AV node is starting to show its age. It's not working as quickly as it should. But if he starts needing medicines for like hypertension or anything like that, it may affect what meds I choose, because I may want to stay away from meds that would slow that even further. So I may want to stay away from diltiazem. I may want to stay away from a beta blocker, because I don't want to stretch that out anymore to the point where he is dropping beats. I wouldn't want to push it forward, but it's typically a normal consequence of aging. Or it shows that, if you guys get a pre-op EKG on a 75-year-old who's had a heart attack before, and it's sinus rhythm with first degree AV block, but everything else looks okay, you may look at their med list and they're on 100 of metoprolol every day. And if you took the metoprolol away, that AV block would get slower. It's because a lot of the meds work there. So it comes, if you had to put a pin in the heart where the pathology is, it's from the AV node itself. It's pretty benign, and it's almost, I shouldn't say pretty benign, it's typically very benign. And it's usually just a marker of either some disease in the AV node or just some medications. Everyone good with that? That's pretty much the simplest one. So then there's second degree heart block. And what do we know about second degree AV block? How many types of second degree heart block are there? Two. So type 1, or what we call Winky Bach, and then type 2. So what is second degree type 1 AV block? What goes on? What do we usually describe as to what's going on with type 1 AV block?
The normal rhythm, and then you just drop one. Is that correct, or is it the other way around?
That's the other way around. So
Okay,
hold on to that
so
thought
it gets
for 5
longer
minutes.
and then you drop
Longer.
Okay.
So the PR interval gets longer.
It was one or the other.
Yeah,
Right.
all right, good. So the PR interval gets longer, and then you drop a beat. So a couple things. So these are the ones that can start to get a little bit challenging to start diagnosing. And there are a couple little tricks to this, and this can even be hard for someone who does this for a living. So if you notice here, you have a P wave, which shows the SA node is working. A normal look, if you just looked at this beat, that's a pretty normal looking complex. You have a normal P wave, a normal PR interval, and a nice narrow QRS. You would think the conduction system's working completely fine. But then you get a P wave and a little bit longer PR interval, and then a beat, then a P wave and a little bit longer, and then a beat, and a P wave and a little, pretty much longer, and a beat, and then the P wave comes and you get nothing. And then you sort of hit the reset button, okay? The second degree blocks, whether it be the one you were describing or this one, which is type 1, is the only one where you're really actually dropping beats. So complete heart block, while the top and the bottom of the heart are not talking to each other at all, you're usually in at least one of the escape rhythms. So your ventricles are doing their own thing, but it usually is at a regular rate. And then the P waves are doing their thing at a regular beat. So you're not actually doesn't look like anything's falling off the cliff. The second degree heart blocks, if you can sort of remember, if it looks like things are just dropping out, you're not dealing with first, because first we said you don't drop any beats. And even third is scary. We'll get to that in a minute. You're not really dropping beats in that one. So the second degree heart blocks are the ones where you're dropping beats. So you have a P wave and a QRS, a P and a little longer, a P and a little longer, a P and a little longer, and then all of a sudden you have a P wave and you get nothing. So a couple of the caveats for second degree type 1 AV block. Number one, nothing beats experience, so the more you see this, the more it helps you. The second thing is, these are the rhythms that when they call us to do a consult on, you'll sometimes see us with like the frickin' telly strip like the size of the table, because this often gets described as it looks like group beating, because you're getting longer, 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 drop, reset. Longer, 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 drop, reset. So if you had a big long telly strip and the person kept doing this, it'll often you see a group of beats like this, and if you did it down a whole strip of paper, you'd see a group, a group, a group, a group, and that's what gets us thinking, is this wanky bot? Because it's just sort of like almost someone resetting the typewriter, losing. You drop one, and then it starts all over again. So you can see this looks like a group of beats here before something misses.
So you normally need something more than just a 12 lead?
Yeah, so the 12 lead always help, but these are the rhythm strips.
Right, so you need a longer.
You may run one for like 30 seconds, and we have the thing there, and we use, we just are measuring out. The hallmark of second degree type 1 AV block, and this is a lot to digest for people that don't do this all the time. You see you drop the beat here, and this is the beat that comes back. The PR interval of the beat that comes back has to be shorter than the PR interval of the last beat that made it through. It's almost like you hit the reset button on everything and it starts over again. Tell people to think about this like the flagger. You guys weren't here, a couple of you weren't here. I keep talking about the AV node as the entrance ramp to the highway. That's the only way for the beats to get to the top to the bottom. And there is an inherent AV delay. Your P wave is not right up against your QRS complex, right? There's a little space there. So it actually protects us that it delays beats just a little bit to make it to the bottom. And I used the example last time, atrial fibrillation. We're thanking God every day that we have an AV node, because if AFib let every beat down to the bottom, it'd be VFib, we drop dead. AFib is throwing beats at the PR, at the AV node as quickly as it can, but the AV node's like, whoa, I can only let so many cars on so fast, and that's what keeps the heart from going 400 beats per minute, the bottom of the heart. So when the AV node starts doing this, I tell people to think about it like just having a construction flagger there. Like it's slowing you down, and then all of a sudden he's got to stop cars for a second. And then traffic can go through, up, stop. And every fourth or fifth car, it has to do that, okay? This is still disease in the AV node itself. Even though this sort of looks ugly and scary, believe it or not, it's still pretty benign. You don't necessarily need a pacemaker because you have this. Again, it just lets you know the AV node is not working all that well. Every once in a while, it's just sort of running out of steam and not letting a car through. It would affect you wouldn't want to give someone that has this like 100 of IV metoprolol or PO metoprolol. You'd want to stay away from meds that slow this even further. But this in and of itself tends to be a pretty benign problem, okay? We used to tell, it's terrible. This is also known as like wanky bot. I'm not going to go on video with this. All right, so forget it. It's a dirty joke, but it makes you remember, but I wasn't being videoed, I'd tell it. So short PR, longer PR, longer PR, longer, you have a P, and then you drop a beat, and then it starts all over again. So think about the group beating. The whole thing with these bradycardias, you have to sort of trust yourself and trust your eyes and know what you're thinking, and we'll get to that as we practice a couple of these. So the one below it, you can see here, like sometimes it's hard to start with what you get on the rhythm strip. So here we have this P wave or some type of wave that doesn't give us anything, so we don't really know what's going on here. But then we have a P and a QRS, and then a P and a little bit longer and a QRS, and a P and a little bit longer and a QRS, and then we get a P wave and it's nothing, okay? So these are both second degree type 1 AV block. But what's the difference between the two? And this is where it's a little bit subtle. They are both second degree type 1 AV block. But if you notice here, the P waves are coming in at a pretty good clip. So like the sinus rate is not bradycardic, you're just dropping beats. Here the sinus rate's also a little bit slow. So now maybe the SA node has some disease as well. We know it's type 1 AV block, so we know the AV node has something going on also. And what do you notice about the QRS down here? It's a little bit wider than the one down here. So this one starts to say, all right, if the QRS is wide, now the wires in the ventricle may not be working so well either. So the subtle difference between these two is everything seems to be working good here except where it's starting to drop some beats, so maybe they only have a problem at the AV node. This guy's sinus node's a little slow. He's dropping beats, his AV node's not working well, and his QRS is wide, so the wires, once it gets through, aren't working so well. This guy may be a little bit sicker than the guy up here, only because you're starting to see disease at multiple levels in the heart. The only one you could say here is their disease right where he's dropping the beats, which is the AV node. Does that sort of make sense to everybody? So when you start to see a wide QRS to go with it, it just lets you know there's other areas that aren't working so perfectly, just to have your antenna up to see what's going on. So that's second degree type 1. Second degree type 2, you had already said, what was second degree type 2, because you described it perfectly.
You just get a beat, and a beat, and then you just drop one.
You just drop it with no warning.
All
Okay?
the intervals are normal.
All the intervals are normal, and then you may not even have a delay in the AV node, which tells you that if you had to put a pin in the heart, now we're starting to get lower in the heart. So as the AV node turns into these bundles, as you come through the AV node, where am I? You come through the AV node and go into these wires. There's a little area right below the AV node called the bundle of His. Not that you guys have to know this, but it's really where the bottom of the heart starts, and that's where the disease is in this one. So, you know, because don't forget, look at these beats right here. P, QRS, P, it's a normal PR interval, so cars are getting on the highway okay, and then all of a sudden, every once in a while, a car falls off the highway. It's just not making it down. Right below the AV node, there's a flicker where all of a sudden the lights it's like the lights flicker in a storm and you drop a beat, but then everything picks right back up. This is actually starting to become a more, I don't want to say dangerous, but people that have this AV block, second degree type 2 and then third degree, typically end up with a pacemaker because it comes without warning and it's starting to show that there's disease in those ventricle areas and we don't like messing around with the ventricles, okay? So this one, P, QRS, P, QRS, P, nothing. P, nothing, and then right back to as if nothing ever happened before. You don't get a resetting because there's no warning. This is below the AV node. Same here, P, QRS, P, QRS, P, QRS, P, nothing. P, QRS, P, QRS, P, nothing. So again, you're dropping beats. This doesn't always look like necessarily the group beating thing because things aren't like resetting. This is coming much more randomly. You may see 15 beats in a row, and then 2 dropped, and then it goes another 5 beats, and then 1 drops, as opposed to the Wenke Bach where the AV node sort of has to reset after it happens. That's where you get sort of like the group beats together, all right?
So that's more concerning just because of anatomically where the disease
Correct.
is, rather than what's actually happening with the beats dropping.
It's well, yeah, so where it is, what you said makes it more concerning, so correct. Where it is anatomically makes it more dangerous, and it makes it more likely that something like this is just going to go for like 11 beats at some point, and then the person's going to pass out or do something.
But it'll drop for 11 consecutive.
It can, yeah. So this is a pre-marker of saying nothing's kicking in here. Okay. Now, based on what
Those P's should get the same interval all the way down. Right?
everything should be. It's just like a random dropping of the beat. So if you measure these P waves, they're going to march out pretty equally. All right. Of these two, if these are both second degree type 2, you have the top one and the bottom one. Based on some of the other stuff I've started to teach you, who do you think might be sicker, the one on the top or the one on the bottom?
The top,
Because what else do you see?
wide QRS.
Wide QRS, very good.
Yes.
All right, you guys are learning. All right, so good. So these are both second degree type 2, but you would say, God forbid, something started to really kick out here. This guy's got a nice normal conduction system in the bottom of the heart. This guy already has he's got a bundle branch block most likely. So one of his bundles doesn't work down there. Now he's dropping beats. This guy you'd be worried has less to bank on. You would think if this guy started getting sicker, he would eventually start to look like this if you just sort of watch this for days or weeks on end or something like that. All right, so that's very good. So there's P waves, there's a QRS. It can look very normal for long, long strips of time. So this is, I know you guys don't see this all the time because you're more surgical. This, I would say probably 5 times a year, you know, we get 1 million admissions here, not so much now, but for syncope. Person passed out, can't figure it out, they come in, you know, all it takes is someone to have like this much of not heart beating and they can pass out, especially an older person. Put them on the monitor here, completely normal, nothing bad. Echo's fine, carotid's fine, so we send them home and we put them on a monitor, and then 30 days into it, nothing happens, then they pass out again. You know, we can't figure it out. So we do these little loop recorders, which are little monitors that get implanted under the skin where we can watch them at home for like 3 years in case something happens. And then like 7 weeks into it, boom, they hit the button that something happened, and then we all of a sudden, that's how random it can be, but it's enough to, you know, if it's a 7-year-old that falls and breaks their hip, or then it's your guy's problem and our problem, you know, so it's a real thing. So this really, that's why this is so dangerous, because it sort of comes without any warning, and the lights can go out on these people like that. This tends to be older, sicker, you know, wiring, older, sicker ventricles. This does not usually happen to young, healthy people.
So if they are dropping and they're passing out and they do break their hip, and they need to get a pacer, right?
Yep.
Does that pacer need to be done before the surgery?
Good question. I think that depends
Or
on,
surgery?
probably, it depends on how, so if they're truly stuck in it and they're asymptomatic, maybe yes. If it was a transient thing, don't forget, you could temporarily get the heart through a lot of things. They may wanna, they'd probably go home with both.
Okay.
And I was gonna, I'm gonna give you guys a talk about AFib either later in the week or next week. Don't forget, to get someone through surgery, because we've done it before, we can say, yes, they're prone to this, but just, if you think about your ACLS protocol, what's the treatment for symptomatic bradycardia, regardless what it is? What do you give if someone's acutely bradycardic? What medicine do we give? Atropine. So you can give atropine to try to speed up the heart. And then if you follow the ACLS algorithm, if atropine doesn't work and you think you're headed towards like a pacemaker type thing, especially in the urgent or emergent setting, one medicine that works beautifully, and you can buy yourself even a couple days with it, is dopamine. So dopamine will speed up the heart. It's like total adrenergic surge to the heart. I would usually say if someone like fell, broke their hip, we know they're doing this, but they're not like, their pressure's not 50, they're not stuck in it every minute of the day. We would say hang some dopamine, let their heart race at 100 beats per minute for a couple, get them through it, and then we'll do our part afterwards. So that's a good question, but you could go either way with that. I would say if someone was doing this constantly, especially someone like this, you wouldn't want to put them through general anesthesia because you'd worry the heart would totally crap out.
You gotta do pacers here.
Yeah, absolutely. So actually, if you remember the case you and I got stuck with, Rebecca, it was a shit show. It was in the, pardon my French, it was in the ER, but the person had terrible metabolic stuff going on, and they were, if you remember, they wanted to intubate him before we started doing the pacemaker, and this guy was in a junk, he was like in an escape, he was sick. And my concern was if they took away that, just, you guys see it, if you intubate someone, everything goes away. Their drive goes away. I thought he was gonna flatline if they, the fact that he was struggling a little bit was enough to keep his heart from completely, so we had to pick one of the, you go up for the, so we decided to do the wire first. And it ended up being his potassium was 15, but that kind of thing where what's that?
You don't know that. So
we don't, right, but they were gonna intubate him to, and I was afraid that drive he had of struggling a little bit was probably keeping the heart from completely, just like the pressure bottoms out, everything bottoms out when you intubate him. So you have to be careful. And then there's third degree AV block, which can be difficult to pick up sometimes, but what does third degree AV block mean, at least by definition?
Everybody's doing their own thing.
So the atrium and the ventricle have stopped talking to each other. Someone snipped the wires somewhere in between. So the atrium is beating at its own beat, and then the ventricle, because it doesn't sense anything coming from the top, either the ventricle or the AV node, wherever the problem is, the generator is going to kick on because it thinks it's not listening to anything coming from the top. You're not really dropping beats, and the escape rhythm that you flip into tends to be a regular rhythm. So you can usually march out either with calipers, and I don't expect you guys to carry calipers, but a piece of paper works like a beautiful set of calipers. If you can find 2 beats, like we're doing the QRSs here, you could march those out and see these guys are right on each other here. And then you could do the same thing when you find P waves, okay? The hardest part of third degree heart block is sort of convincing yourself is what is going on. Because all of a sudden you're gonna see a P wave and you have to decide, and this is the hardest part, and I don't expect you guys to know this coming out of this, it takes a lot of practice. You say, all right, I see a P wave, and then I see maybe some QRS activity somewhere. Is that P wave responsible for what I'm seeing next? So, and that's truly the $1 million question here. So the bottom is a better example here. The other thing you have to do when you get to these kind of things, you can't always start at the beginning. So the P waves should march out at their own rate, and the QRSs should march out on their own rate, usually slower, because your body, when it's sick, if you're in heart block, usually your body knows something's wrong, so you're gonna get adrenaline and all that stuff. Your P waves might be coming in pretty fast, but your QRSs are just gonna be moseying along, not listening to any of that because the backup generator's on. So sometimes things will happen at the same time. If the P waves are going and the QRSs are going and they're not listening to each other, sometimes you'll get a QRS right on the same time you're getting a P wave and you won't see both of them. So that's why you have to sort of trust, all right, I'm marching and I don't see something, but I'm gonna keep marching to see if it sort of picks back up later in the rhythm strip. So here we have a P wave and a QRS, and this could be a completely normal looking complex, right? But then we look here and we see we have P wave and maybe this is a first degree AV block now, and then a QRS. So we don't really know what's going on here. But now we have sort of something here, and we don't really know what's going on. And then we have a P wave and a QRS, and a P wave, but then we have this beat where there's really no P wave anywhere. There's some subtleties that you can pick up on here. So the first thing you would do is like, all right, I'm gonna see if I can follow the P waves through this stuff. So I have a P wave here and a P wave here. At least I can convince myself of that, right? So now we're gonna march along. If you guys, I don't know if you guys have this thing. Look at the second, you see the T wave here? You have the QRS and then the T wave. Notice that little, I mean, you have to sort of do this for, I don't know if you guys can appreciate, there is a tiny little abnormality in the T wave here. That's a P wave hiding out in there. It just doesn't look like the other ones, so that's why you gotta trust your eyes. So I have a P wave and a P wave, so these should march out. So all of a sudden it's telling me something should be in here, but I don't really see anything, but the whole key is to not give up. See, all right, I don't see anything there, but I'm gonna keep going. So I'm gonna move it along. Oh, what do you know? Now all of a sudden I'm still lining up with this one. And I'm still lining up with that one. This one, I know it's subtle. This T wave looks a little peaked. It's because the P wave is like coming in at the exact same time. And even if you didn't trust yourself, you'd keep marching, and then you'd get something right here. So those P waves we describe as sort of marching out. The other thing that's sort of a giveaway, and it's a little bit difficult, even though it's possible, you have this one, and most importantly, this little blip right here, if you trust your lines, is a P wave right up against the QRS. It takes time for a P wave to go through the AV node and down to the QRS. When these two things are right next to each other, they're too close together for them to be listening to each other. For that P wave to be responsible for that QRS, it's got to go through the AV node, even if it's not the longest thing in the world. When they're butt up against each other, they're happening essentially at the same time. This little P wave right here is not responsible for that guy. He's not listening because it can't travel that quickly, okay? So these are the P waves marching through. And the only way really to do this is to be patient with a piece of paper calipers. And if you measure these QRSs, they're marching through at their own rate also. Now the QRS is narrow or wide here?
No.
This is wide, so these are narrow.
Narrow.
So we would describe this as, you know, he actually has P waves, so it's sinus rhythm, because he does have P waves, but it's complete heart block. And this guy, if you count these, it's 300, 150, 100, 75, 60, about 55 beats per minute. He has a junctional escape beat at 55 beats per minute, because these guys are narrow, so they're not coming from the ventricle. And we said the AV node will kick in at about 40 to 60. If the QRSs are wide, this rate, this is like 30 beats per minute. This is what we would call a ventricular escape rhythm. So you see how the QRS is wider and slower? This is narrower and faster, just the QRSs.
Okay.
So this guy has a little more ways to go before he gets sick. God forbid if these things ever kicked out, he's got nothing left. There's no generators left to kick on. That becomes asystole. All right, so this guy is sicker than this guy, even though they're both in
Yeah,
third
because
degree.
he's not
heart.
getting really a QRS at the top, right?
I didn't hear both.
Sorry.
No, go ahead. What were you saying?
So there's not really a QRS on the top one. It's just
These
like
are
a P
QRSs.
wave.
These are them.
I know, but they're not like, they look wide.
So they're coming from the
And so
ventricle.
they're, yeah.
So if you're in heart block, something else is going to kick in to beat the heart. So the sinus node's done because it's not listening to the sinus
Gotcha.
node. So either the junction is going to kick in, almost like a generator, like a lighthouse.
Right.
And if the junction kicks in, because it's from the AV node, it's going to be narrow, and it's going to be about 40 to 60 beats per minute, and which is a pretty stable escape rhythm. It's actually not a terrible thing to be in.
That's another thing that points you to where it's coming from, if it's ventricular. or if
Absolutely.
it's-
So
okay.
if it's narrow, it's coming from higher in the heart. If the junction doesn't kick in, your last ditch is the ventricle to kick in, which is going to be wide because it's coming from the ventricle, but it's even going to be slower. It's only going to go at 20 to 40 beats per minute. So those people, this guy, it's very rare that these people have this and are not somewhat symptomatic. I mean, this is like slow and not coming from the normal rhythm. So this is complete heart block with a ventricular escape rhythm. That makes sense,
Is that
everybody?
what you would call that, like if I'm calling you on the phone?
Yeah, you'd say, I'm concerned, you'd have my attention to complete heart block. And then after that, you'd say, but I'm really concerned because his QRSs are wide.
Okay.
So I'm worried that this is coming from the ventricle.
Okay.
If I looked at it and if you guys sent me a picture of a strip and I saw at least the QRSs are narrow, I'd be like, all right, look, let's make sure he's not on any metoprolol, nothing that's precipitating this, make sure his lights are okay. But I would reassure you that as long as his QRSs stay narrow, we don't have to run in and do anything crazy. Someone like this, you'd want like atropine at the bedside, you probably want the transcutaneous pads on him, because if this goes, he or she is going with him. All right?
Can you describe the bottom one as a junctional
Yeah,
escape?
because it's narrow, and
Right.
it's about 40 to 60 beats per minute. The
What-
narrow versus the wide.
What's causing that ventricle to contract on the bottom one? Not the ventricular rate, right? Like, 'cause it's not,
This one here.
yeah,
So you're still getting electricity from the AV node, and it's going down the fiber. So it is contracting. It's just not coming from the sinus node anymore. It's still getting an impulse. It's just not, usually when the impulse comes from the sinus node, it goes down the chute.
yeah, right.
Now that's not coming, so now it's just coming from lower down, and it's still listening. I mean, this is still electricity coming through the heart.
Okay.
The problem is this is electricity coming from the ventricle itself.
Yeah, yeah.
So there's that whole thing, electromechanical coupling. The heart takes a signal and then does something with it. So it's still getting a signal, it will do something. It's just this is the last, the heart has nothing left once you're in this. If the wiring wears out after this, there's nothing left to kick in. The only point I have between this and this is, God forbid this decides to deteriorate, you would think the next step for this person would go from here to here, if that sort of makes sense, because there's something left to kick in. If this decides to go away, there's nothing left to kick in, then we're flatlined. All right? Don't forget, for the purposes of ACLS, which is, I mean, we're going through all this stuff, the biggest thing that drives how aggressively you guys have to treat someone acutely in ACLS is not what rhythm they're in, it's how symptomatic they are. So someone can be in complete heart block, and yes, they're not gonna go home, but again, if you follow that algorithm down, if they have any symptoms, you give them atropine and then maybe some dopamine. If they don't have symptoms, it's still monitor and observe. Doesn't mean they're not gonna go home with without a pacemaker, just means they don't need a pacemaker like that second. So that we have plenty of people that come in complete heart block, and you know they have either a junctional escape or an escape rhythm where they're hanging in and their pressure's 120. You do not have to throw a wire in them that second. Doesn't mean they're not gonna get a pacemaker before they go home. But for the purposes of ACLS, the biggest thing with the heart blocks and the bradycardia that drives your treatment is symptoms. Any symptomatic bradycardia needs you to do something. Any asymptomatic bradycardia is monitor and observe. Now, it doesn't mean to not have your ducks in a row, have the atropine at the bedside, you can put the pads on, whatever you feel comfortable with, but you don't have to jump in and do something just because they're in complete heart block. If they have a stable mentation, stable blood pressure, you call your specialist and then you figure out when the next step of action would be.
Is there anything interval or interim while you're gathering the information and calling the
Yep.
cardiologist that would be a first thing to do before you call? Is there anything like that that we should, I mean, obviously get labs?
Yeah, I would say honestly, it wouldn't even be, unless they're like a new dialysis or new renal failure, you would just check the day's labs and see, all right, oh
Okay.
shit, someone missed potassium of 2.1, we forgot to
Okay.
replete, stuff like that.
Okay.
But there's not, or
There's
the
not
other.
like a first line, immediately do this and then call?
No, because
Okay.
it all depends on their symptoms. So if you say,
Right.
oh my God, the pressure's 80 and they're in heart block, you gotta give atropine while you're calling,
Yeah,
obviously.
okay.
But if they're stable, the biggest thing would be, what they're in for, any electrolyte abnormalities, and obviously the meds. Like, oh, well, I just looked, we gave him, 500 mics of digoxin about 6 hours ago. You'd be like, all right, let's try to ride that out. Or he's on, plenty of the people that we see that come in like this, there are a lot of, again, this is not young, healthy people. Usually this is older people whose wiring is starting to show its wear and tear. They may have, they take 360 if they'll tias them. We will give them, as long as they're stable, we'll give them 2 or 3 days, because once you put in a pacemaker, again, not that it's the end of the world, but once you got it, you got it. It's very difficult to remove a pacemaker, so God forbid it gets infected. I mean, when it turns into a mess, it becomes a mess. So if someone comes in with a big nodal blocking agent on board, like an old lady who comes in with this, but takes 100 milligrams of metoprolol every day, we will try to drag her feet and let her sit here for 2 days without the metoprolol on board to see if this sort of goes away. So the meds, or again, we'll check obviously their electrolytes on the way in, check their thyroid, stupid stuff, easily reversible stuff. But after 2 days, if they haven't had any metoprolol, 2 or 3 days, and their heart rate's still doing this, or it usually just leads us there. But that's the biggest thing. Is there a med that's slowing down the heart, or is there some type of crazy electrolyte abnormality?
So it sounds like a ventricular escape. Like if you look at some pulmonary patient and they're accessory breathing, eventually they'll poop out.
Yeah.
Are you have so much time if you're on ventricular escape, or you can go on for that?
Probably not forever. Ventricular escape's not the most stable rhythm in the world.
Okay.
So I would say if someone has a ventricular escape rhythm, usually we're sort of forced. That's an ugly looking rhythm. That's like sort of pre-code.
Okay.
So I don't think,
Maybe
I think if you
talk
guys called me and they were in complete heart block, sort of, unless you knew as soon as you intubated them that, you know, we'd probably get through that if we had to. If someone was in a ventricular escape rhythm, I'd be putting a wire in.
Okay.
I would, almost guaranteed, yeah.
Okay.
I wouldn't sleep on that, cause if it you don't have the time to start getting your shit together once it goes away.
Okay, so you plan as if it's gonna go.
Yeah, ventricular escape is pretty inherently unstable.
Okay.
You can have a lot of people that sit around like this though for 2 or 3 days, and that junctional escape, for whatever reason, is a pretty stable escape rhythm. Like you can hang there for a while. The reason it's an escape rhythm, it's just sort of like a lighthouse. The reason I talk about it like a generator. Don't forget, your sinus node goes with you. When you run, you go into sinus tachycardia. When you sleep and relax, your heart rate, if you look at your heart rhythm throughout the day, it goes with the ebbs and flows of like life. When you're spazzed out or you're running, it goes faster. When you go to sleep, it goes slower, it's up and down. When you're in like this junctional escape rhythm at like 55 beats per minute, if that's truly what this person is in right here, like you could walk them up and down the hallway 10 times and try to make them out of breath. The heart would still be stuck at like, that's how we sometimes actually sort of, it's still stuck at like 55 beats. It just won't, it's not listening to anything. It's not the normal, it's literally that's why I describe it like that. We will have patients where we'd say, all right, well, you're a little bradycardic, you've been off the meds now, let's get you, we'll keep you on the monitor, try to walk up and down the, like let's kick you in the butt a little bit, see if we can get things moving. When you're in one of these escape rhythms, you could have them run up and down the hallway and they're still gonna be like 50, it's not listening to anything. It's just that's why it's an escape rhythm. That's how we sometimes have to tell them. All right. So I know that's a lot of stuff, and I don't want to bore you guys to death. You're not cardiologists. Why don't we go through a couple of these? We don't have to do all of them today, and then we'll take it from there. You guys want to do the first package?
Sure.
I gave you? I think those are a little better.
Do we want to?
You don't have to.
Sorry, it's okay, we're doing it, we're doing it.
Go to the bathroom without raising your hand. You can do whatever you want.
Like, you know, you look, I know for me, like,
That's scary.
I learned all these different rhythms and like kind of remember like the criteria for it.
Yep.
When you're looking at a 12 lead, you kind of just get distracted by other things. Like, do you have like an algorithm? Like, I start, I look at the rate, and then I look at this, and then I look at that.
Yep. So the way we do it, not that you guys have to go through all this, I typically go rate, rhythm, axis, interval, like RAIM is what I was taught. Rate, rhythm, axis, interval, morphology. For you guys though, the way I have you guys deciphering things, because you guys are going to do these more in the acute setting, and that's how I'm sort of approaching it with you guys. The first big picture thing, so you know whether you got to really have a hop in your step or you can take a breath, is what's the rhythm look like? Is the QRS narrow, which lets you know it's a rhythm coming from the top of the heart? Is the QRS wide, which means it's something more ventricular in nature? And then is the rhythm regular or is it irregular? And that sort of helps you go through these things. Then you can start working on the rate and all those kind of things. So does someone want to take a crack at this first one and sort of how you'd approach this? This is a little bit funny looking, so just so as you guys appreciate this, your EKGs, when we do one here, this has 3 rhythm strips. That's not what we usually get. So if you guys did an EKG here, just so you know, you would get, these are all your leads up top, the limb leads and then the precordial leads. And then it's usually lead 2, you would get the 1 going across the bottom. Someone set the machine here that you actually have 3 rhythm strips across the bottom. That's just not typical, but you know, it's extra from, you know, they're all the same thing. So like when you see lead 2, if you notice it's identical, the lead 2 rhythm strip is the exact same thing as lead 2 right here. It just keeps on going. So what does the QRS look like here? Is it narrow or is it wide? Narrow. So we know we're not dealing with ventricular tachycardia at least, so we can take a deep breath. So now the QRSs, do they look like they're coming at the same time? Do they look regular? Do they look irregular?
No, they look
Look irregular.
They look irregular. So when we start thinking irregular, what's the first rhythm that comes to our mind? AFib. So what's the diagnosis of AFib? It's irregular, and what else has to be lacking? No P waves. Does anyone see P waves here?
I didn't think I did.
No, I don't. I
Guess
agree.
not.
No. So the best place to look for P waves. Don't forget, the heart beats when the heart's beating normally, it beats from top to bottom. So P waves are going towards the bottom of the heart. So usually when we're looking for P waves 2, 3, and AVF, those are the leads that are showing us the bottom of the heart. That's why the P waves look like this in there, because they're going towards those leads. So you look at lead 3, you look at lead 2. It's pretty squiggly lines there. I would agree. So there's no P waves. It's a narrow complex QRS. It's irregular. So everyone agree this is like AFib? okay? Couple things not to, Joe picked this up, and again, just because it's AFib, that's wonderful. The other thing you don't want to ignore, now people that I'll go over this more when I go over the AFib stuff with you. There's AFib that people live in, there's AFib that people flip into. You also have the ST segments when you come to EKG. So if someone's having chest pain, that's where we start to see changes in the STs and the T waves. You'd also not want to blow off if the T waves were markedly elevated or ST depressions. That's in the ST. We'll get to a couple of those. I think there's a couple practice ones here. That would be more like the morphology and anything else going on. So this is pretty, those T waves are pretty benign looking. This looks like someone that's just sort of living in a atrial fibrillation. Anyone agree on that one? All right. Let's go to the next one. I think we did this one last time, but a couple people weren't here. This is one of the tougher ones.
QRS is regular, narrow.
Right, so if you look in V1, for instance, that's a nice narrow QRS, and they are coming on pretty regularly. So at least we know we're not dealing with like VT here. The other nice thing is if it's regular, what can't it be? It can't be AFib, right? So that all of a sudden we just took that one off the differential also. So we have a regular rhythm that's about, if you count the rate, about 140 beats per minute or so. What do we think could be going on here?
Sinus tachycardia.
That's one possibility, sinus tachycardia.
Or it's flutter, because it
Tachycardia.
has sort of
So
a sawtooth
sawtooth.
look, but
Does anyone ever know what we're talking about with the sawtooth thing? The guys that weren't here last time?
Yeah.
All right. So good, so this is exactly what we do. Is this sinus tach? Is this atrial flutter? The other thing could be SVT, but these are not, this is pretty slow for SVT. SVT is usually faster than this. The QRSs are closer together. So I 150% agree with you that this is either sinus tach or SVT. And I'd also tell you that 70% of the doctors in here in this hospital could call this wrong also. So the only thing I can tell you is nothing beats practice. So just from me having looked at tens of thousands of these between training and everything else, when I see something like this, and I don't expect you guys to do it, it jumps out to me as like an atrial flutter type thing. I mentioned to the people here last time, if you watch what I do on the video and stuff, anytime you have a narrow rhythm, a narrow QRS rhythm that's right around 150 beats per minute, right on there, it's perfect for how atrial flutter likes to work, because the flutter waves are going around the atrium, and sort of every other flutter wave makes it down. So the thing with sinus, this easily could be mistaken for sinus tachycardia, and we see this all the time. But the thing is, coming out of lead look at lead 2. Right after you come out, I already have the arrows here, so I don't know if you can see it. Right after the QRS here, these little upside down things, those are the actual sawtooths. So those are actually upside down P waves in there. Now, for the guys that were here last time, try not to answer. Let's go to the next EKG real quick before we finish up this one. Everybody look at that one. And even though it says it right on the frickin' top of the thing, look at 2 and 3. That's pretty that's sawtooth, right? Like everyone could agree, like you see something like that, and that's pretty distinct, the atrial flutter. Rebecca, you see what I mean by the sawtooth stuff? So if we thought this was, going back to the one before it now, everyone looking at the one that says atrial flutter on it is pretty comfortable saying that's atrial flutter. Going back to the one that we're not sure, what could we do to make this one perhaps look like this one? To say, oh, there it is, it's atrial flutter. Slow it down, right? So if we just slow down what's going on, we may see more of the flutter waves. How do we slow down what's going on? All right, so so we got to slow down the AV node somehow, and then we'll see more of the flutter. All you need to see is literally, when you're looking at atrial flutter and I'm trying to figure out what's going on, I need to see like that much of it, I'm like done. I mean, most times if you just see a couple of the flutters, you know what you're dealing with. So yes, anything that slows the AV node, for you guys that weren't here last time, I don't want to go over it all completely, but atrial flutter, there's something going on in the right atrium where the heart's there's a circuit that keeps going around and around and around. And every one of those sawtooths is a loop that's going around in the atrium itself. And what's happened is every time the loop goes all the way around, it tries to go down to the bottom of the heart. But this race car is going around in the top of the heart at 300 beats per minute. So that's the rate, the atrial rate of atrial flutter. The problem is the AV node will not let 300 beats per minute down. So it lets one down and then it makes another lap. It says, can't keep up with that. But if it makes every other loop, 300 divided by 2 is like 150. So what you're trying to do is the heart's fluttering, 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 fluttering. If you just slow down that AV node, you'll see more flutter waves before the beats make it down. What's a beautiful way to slow down the heart without having to give any medication?
It's a vagal.
Vagal maneuver.
Yeah.
So if you had someone like this, the first thing I would do, I'd have them on telly, I'd be staring at the screen, and I'd like, Mrs. Jones, you're not gonna like this for a second, just hang in there, and I would go and push. Or I'd say, hey, Mrs. Jones, do me a favor, can you take a deep, deep breath and try to push it out but hold it in, or pretend you're straining up. Have them try to do something, and all you want to do is slow down that AV node enough that I'll see flutter, 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 even if it's for 3 seconds, but at least there it is. I know what I'm dealing with now. And the reason that's important is atrial flutter, much like atrial fibrillation, for patients that are in it and they don't know they're in it, are at risk for blood clots and all those kind of things. So you don't want to just acutely, screw it, I'm just going to fix it, because if it is atrial flutter, they could have a clot in their heart. But the vagal maneuver, or if you had to, IV low pressor, adenosine, because it's very short acting. Anything to slow down that AV node will bring out the flutter waves. So what we would describe this one is, if I was interpreting the EKG, this would be atrial flutter with 2-to-1 conduction. So for every 2 loops of flutter, 1 beat is making it to the bottom. This next person, the third one we looked at, would be atrial flutter with 1, 2, 3, 4-to-1 conduction. For every, the atrium's got to make 4 loops for every beat that's making it down. So this person may be an 80-year-old that we let live in atrial flutter that takes 50 metoprolol every day, or 120. This person's on something that's slowing their AV node, so only every 4th beat is making it down to the bottom. Does that make sense to everybody? Yeah, so if you count here, the hardest thing with flutter is finding, so you can see, what flutter is, if you think about it this way, every flutter wave, every one of those sawtooths is an upside down P wave. Because it's going, instead of going from top to bottom, the way that race car is going around, it's going away from the bottom. So you count flutter waves from the bottom and not from the top.
Oh.
So here's one flutter wave. I don't know if you guys can see this. 1, 2, 3, 4. Those are your 4 flutter waves right there. Those are upside down P waves, essentially. It's atrial activity that keeps going around in a loop and a loop and a loop very, very quickly. But so it keeps hitting this AV node. Every time it makes a loop, it wants to go down. The AV node says, I'm only letting a certain number down. That first EKG we looked at let every other beat down, which is pretty fast. Like if any one of us at our age, I would expect if we flipped an atrial flutter, that's sort of what you see. If one of us started taking 100 of metoprolol and flipped into atrial flutter, you'd probably see something like this, because that AV node is not letting as many cars through anymore. So it's making the atrium keep making loops before it lets a beat down. So this is like same thing with AFib, it's just rate control. We're controlling, that AV node is the gatekeeper to the bottom of the heart. When we give medicines like diltiazem, when we throw them on metoprolol, digoxin, we're telling that AV node, all right, construction flag's going up, you're only letting half as many cars down now. And that's exactly what this person is doing. It's still the same rhythm, there's still, that atrium still, your atrium, if you marched out these P waves, the P waves are only 1 box apart. These P waves are going at 300 beats per minute. But the ventricle is now going 1/4 of that. All right?
So same thing for flutter, like we talked about with fib, kind of 2, 3 AVF to kind of get a better sense of
The
those-
P wave
those
activity.
flutters.
Yep, those are the best leads for. Occasionally, don't forget when you look at the precordialoids, V1 and V2 sit right on top of the atrium. V1 and V2 sit right up here. So sometimes, like in this one, you'll get lucky. You see V1 has beautiful looking. I mean, at least you can see here. It's going to be the opposite. Don't forget 2, 3, and AVF are here. V1 and V2 are up here, so the direction is different. But at least you can say here, this isn't sinus rhythm, because there's a ton of these things. Boom, 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 boom. So you would see up here, and it's not AFib because these are definitely distinct looking waves.
And then if you're doing your vagal maneuvers not working, assuming they're not crashing,
Yep.
would you do a low pressor as opposed to making them feel like they're going to die with the adenosine? Or would you
I would actually, the only reason I like the adenosine is because it's so short acting, even though they hate you for it, it's in and out in about 10 seconds. The metoprolol, you got to deal, if it doesn't work or you start having to give more, then all of a sudden you give them a relatively large dose and a longer acting, but then you have to say, all right, well, I'm not fixing anything here, and now I'm giving them meds that are lowering their blood pressure, I'm running out of rope to work with here. I would just say, look, you're not gonna like me, but let me get, and again, you just need to slow it down, you're not expecting to break it. Adenosine works at the AV node, it shuts it down. So if someone's in atrial flutter, and you shut down their AV node, you're just gonna see sawtooth, 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 it wears off, and then you start to see the QRSs come down again. So adenosine can be used for diagnostic purposes to figure out what the hell's
So
going
we're
on.
breaking it just long enough to see that.
Yeah, you're interrupting it. Because the
Good.
word I use for breaking,
You're
we're talking about,
exactly- I got you.
SVT is actually working, it goes in the AV node itself.
Mhm.
So when you give adenosine for SVT, you're actually giving a medicine that's in the circuit itself, and that's why it should go away.
Okay.
So you can use it either for diagnostic purposes or actual therapy. If you think they're an SVT, you're giving it for a therapeutic purpose. You're trying to make it go away. So for atrial flutter, you're interrupting the connection. For SVT, you're actually throwing a grenade right in where the circuit's trying to go, and that's why it goes away, if that makes more sense.
Yep.
So their rapid rate per flutter, do you treat them like you would AFib, like a partisan drip?
Yep, exactly. It can be harder to, believe it or not, it can be harder to slow down atrial flutter than atrial fib. Because the atrial flutter is coming around at such a regular rate. Don't forget, AFib is like 400 beats per minute. So if one beat's not hitting the AV node, another one is like, it's constantly being bombarded. So the AV node is more in it's easier to be in like sort of a refractory period. This AV node and atrial flutter, it's only getting hit every time this thing makes a loop. So sometimes if you don't catch it perfectly, these loops are still able to make it through, or it'll go from, you can't slow it down until all of a sudden there's like you have 7 seconds between beats. So it's typically harder to slow down atrial flutter. But you guys wouldn't have to deal with it. For your perspective, you would treat it the same. IV diltiazem, IV metoprolol, something to slow it down. All right, let's go to the next one. Do a couple more of these. So what do we notice here? This narrow or wide?
Narrow.
And regular or irregular?
Regular.
Regular. So we've already taken ventricular arrhythmias out of here, and we've taken atrial fibrillation out of here. What do we notice about the rate of this one?
150-ish, 140-ish.
Well, two full boxes would be 150. If you find one, you think it's faster than 150 or slower than 150?
It's a little bit faster. It looks faster.
So one whole box, I'm looking, just so you guys know, you try to find a QRS that lands right on one of the big lines, so I'm looking at this one right here. So if it went to that, if there was another beat there, that would be 300 beats per minute. A whole second box would be 150, so it's somewhere between 150 and 300 beats per minute. So this is about 200 beats per minute. It's narrow and it's regular. So what does your gut tell you this one probably is?
Is,
Say it.
yeah, SVT?
SVT, does everyone buy that?
Mhm.
Narrow, regular. And what will we do to try to break SVT, some with an SVT? So that,
maneuver.
very good. So you always try to do without a medicine first. So the first thing you do with someone with vagal SVT is try vagal. Tell them everything I just showed you. If that doesn't work, we give adenosine. What's the dose of adenosine for SVT?
6,
Very good, 6. And if that doesn't work,
12,
good. That don't work.
12 again.
Very good. All right. And we spoke last time, when you give adenosine for SVT, because it's so short acting, you try to give it as close to the heart as you can. So if they have a central line, you're in really good shape. If you have to give it through a peripheral, you push it hard, you flush it, and you even want to lift it. You try to get it there as quickly as you can because it starts real quick and it wears off real quick.
I was reading something the other night after I was watching your first thing, and I saw if you give adenosine through a central line, it's where I was reading something to consider halving the dose. Is that the
You
thing?
can, although 3 of adenosine, I would say maybe you just stick with 6.
Okay.
I think the doses are meant for peripheral, so you're probably right.
So
The other thing you guys should look at online, and I don't know, the new ACLS guidelines are gonna come out next year. In England, they figured out a better way to do like a vagal maneuver. Not that so much covering the ICU you can do it, but they do something there where not only they have vagal, they actually sort of lift their knees to their chest to sort of increase the venous return, and they showed in one study the effectiveness went up like 30% of having this vagal in this weird way.
So would you not put 12 through a central line then?
That may be a lot.
Okay.
Yeah, I would stick with 6. Usually it works. The thing we spoke about last time is typically SVT, although you guys saw it last time, this typically is associated with a very highly adrenergic state. So the classic like boards question we get as cardiologists is, you know, Julie so-and-so was out partying with her friends and drinking Red Bulls and vodkas, and then she shows up to the emergency department with her heart beating out of her chest, and this is what it is. The adenosine may break it, but if you have a young, healthy-year-old with a 20-year-old nervous system that can really rev it up, it may just sort of, it'll sort of burst right back up and get going again. So in those patients, sometimes the adenosine will break it, and then at least what you're dealing with, then you have to get something like a metoprolol on board, something to try to keep it from sort of constantly revving back up again. What do you notice? Look at V5 and V6. What do those STs look like to you? A little bit depressed. So what does that tell you? Ischemia. So why do you think we're seeing that?
Demand from
It's
the
not
tachycardia.
Very good.
Hmm.
All right. So, but what? So even if they're 25 years old and they should not have epicardial coronary artery disease, like they shouldn't have anything built up in there yet, why would we still see something like this?
Decreased cardiac output.
It's not perfusing,
Not perfusing. Why is it not perfused?
it's going too fast.
Good. You're on the right track. So going
That's all I
too
got,
fast.
Sorry.
That's okay. No, you guys are on the right track. So the heart, the coronary arteries, your heart squeezes blood out to the body, but the
Okay.
heart needs a boatload of oxygen also, right? Those coronary
Oh,
arteries get oxygen-rich blood. When does the heart feed itself? It's systole or diastole?
Fills during systole.
The heart squeezes blood out to the body during systole. So it goes out to the heart squeezes, the heart contracts, blood goes shooting out the aorta to the body during systole, but when the heart relaxes, the blood gets sucked down the coronary arteries in diastole, actually.
Okay.
So the heart feeds itself during diastole.
Okay.
So when you're going at 200 beats per minute, the heart literally does not have enough time to relax to get the blood all the way down and through the muscle. So this is what we call that subendocardial
That's like the
ischemia.
best description I've ever heard.
Well, that's how it works. So
Thank you.
don't forget, I told you guys last time,
Sorry.
that's okay. From the heart's perspective, I tell my patients all the time, the electricity runs on the inside, the plumbing runs on the outside. So when the arteries have blockage or there's flow, it has to go in and then it has to penetrate the muscle to get to the whole surface. When the heart's going this fast, it just can't, it doesn't have time to make it all the way down and through the muscle. So that's why you start to get the ST depressions. This is purely a rate-related phenomenon. It literally does not have time to fill itself with the oxygen that it needs. And that's why patients, even though they're not at risk of like a heart attack per se, they're not having a blockage, they're not going to feel very good with this. Your heart is, it's like running your RPMs at like 9,000. It's just, the engine's not going to like you very much.
So when you see somebody with this strip, do you just assume they have demand, ischemia, or would you get tropes and prove that they're flat, or?
No, so number one, the tropes could back if someone was in this long enough, the tropes don't tell you why the heart, tropes are purely reflective. Troponin comes from enzymes in the heart being released from somewhat damaged cells. It doesn't tell you why.
Right.
So if the heart has inflammation, like something called myocarditis, you're gonna get positive troponin. If the heart has a blocked artery where nothing is getting blood flow and it gets damaged, so you may get positive troponins from this.
I was talking to one of the other guys in the unit the other day,
Yep.
there was a question of somebody end-STEMI versus demand ischemia, and
Yep.
you're saying when you trend them, it's more of a flat trend with the ischemia, even the demand as opposed
Right,
to
so
rising.
the thing is, and this is a whole nother conversation for a whole different day, when someone actually has a heart attack, a heart attack by classic definition is a new blockage in one of the coronary arteries that's actually clogging the plumbing.
Right.
Because it's an acute event, you should typically see a rise and then a fall in the troponin.
Right.
But in someone like this, I wouldn't be surprised if you drew a troponin an hour later was 0.22. I mean, you're seeing it here though, like you don't need any extra evidence to prove that they have.
So you
something.
wouldn't do anything more looking at this?
No, I would treat the problem here.
Okay.
It's not gonna change what I do for them.
Yeah, yeah, yeah.
If they were 78 years old and they had this, all right, well, we should probably go looking for coronary disease also. But if they were 35 and they had this, I'd be like, this is all, just fix the problem. I mean, it's adding, you seeing ST depression tells you they have ischemia.
Yeah.
That's the most direct way to answer your question.
Okay.
All right. Next one. So what do we notice here? So everything looks pretty narrow.
Mhm.
Looks like we got some P waves.
Around
What do you
PR.
notice about the rate here? Are we dealing with fast stuff or slow
Slow.
stuff?
Slow.
Slow, all right. So let's start with the P waves. You see a P, and then a PR interval, and then a QRS, and you sort of gotta walk your way down the rhythm strip and see if you sort of see one P wave for every QRS and agree that they're working together here.
Yep. Looks like they're together.
So the biggest thing with this one is probably the rate, right? So how fast is the sinus rate on this one?
Maybe 50.
Yeah, 40 to 50. For everyone agree with that? The P waves, if you marched a couple P waves out, it'd be about 50 beats per minute. All right, so we know the sinus rate is a little bit slow. So we have sinus rhythm, but it's sinus bradycardia. And what else do we notice here? So we looked at the sinus node. What's the next interval we always look at?
Get the PR now.
Very good.
Yeah, it's widening.
So is that bigger than one big box?
Yeah.
It's from the beginning of the P wave to the beginning of the QRS.
Yeah.
Oh, yeah.
Yeah.
Yep, so
Type
Like-
1.
very good. So we have sinus rhythm, and we're not dropping beats, so it's a first degree AV block. And then how do the QRSs look? Pretty narrow or pretty wide?
Narrow.
Narrow, right? So, but once it makes it through those two stops, the QRSs seem to be working okay. So we would describe this as sinus bradycardia with a first degree AV block. So this is usually someone that's a little bit older, that has a little bit of wear and tear in their conduction system. This could be a 30-year-old healthy person that's fast asleep, that you did an EKG while they're sleeping. This could be someone that takes 100 milligrams of metoprolol for hypertension. Things are just a little bit slow, but nothing inherently dangerous here. And the ST segments look okay. It doesn't look like they're having ST elevations or depressions or anything like that.
Are what the machine spits out accurate at all?
Not bad. I wouldn't trust them all the time, especially when it comes to like the flutters and stuff, but for stuff like this, it would be pretty
Are
accurate.
the intervals?
Yeah, they're pretty good.
Okay.
Pretty good. Now, we'll do one or two more before we lose everybody's interest here. We'll do the next two, and I just want to show you one. Do you think another session of EKGs would be good for you guys, or is this enough already? Let's finish these two and we'll figure out the plan.
Okay.
All right, so let's look at the next one. Look at this one here. I'm not leading the witness here, but before you guys go digging into it the way you need to, take a step back and look at it like sort of a work of art for a second, as opposed to like digging through things. There's one thing I sort of mentioned going through some of the rhythms today that sort of says, all right, well, you take a step back and it looks like things are going in. What does this look like to you if you're just sort of looking at it?
Something dropped.
Like a heart pump.
Yeah.
Something dropped, but what do you notice about sort of the clusters of things? They look like they're in different
They look
groups,
the same.
right? So as someone who does this for a living, that's the first thing that would jump out at me, so I can work backwards and say, all right, this sort of looks like group beating. What's the one that was group beating? It was second degree. Let's see if I can prove to myself that that's what I'm looking at here. Because that first, you know, you have one beat on the end here. I'm sort of ignoring this for right now. But this looks exactly like this, and it looks like it's starting up again right here. So that's how I would. All right, it just gets your antenna pointed in the right direction before you get to work.
Second degree type 2. This doesn't have a prolonged PR, or progressively prolonged PR.
It's progressively
It's subtle, but it is progressively
prolonged and then it
prolonged.
drops.
So look at the one at the very, very bottom, that V5. And sometimes you need even calipers to figure it out.
It's not always as obvious as it is in the book.
Correct.
Now, if it were a type 2 second degree, it wouldn't be the cluster, right?
Correct. You would just have, it would look normal and something would just sort of drop out every once in a
But
while.
it's not.
It's not the group beating because there's no pattern to it. So the best thing I can tell you is, since it's second degree type 1, even though it's prolonging at extremely short intervals, look at the first one in the group and then look at the last one in the group. And there's definitely a prolongation of the PR there, and then you drop the beat. So even though it's a very, very subtle prolongation, by the time you get to the end, that PR is definitely longer than when you start. Does everyone buy that? And then, again, the key one is you drop the beat that comes back, that PR interval has to be shorter than the last beat that made it through, and the process starts all over again.
Right.
So this is like the flagger, the flagger, the flagger, stop. Flagger, the flagger, the flagger, stop. Things are making it through the AV node a little bit slowly, and eventually a car is dropping off. The QRS looks narrow, so there's nothing going on with the wiring in the bottom. So this is not the easiest thing in the world, but this is pretty classic second degree type 1 or Wenckebach AV block. Longer, 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 drop, reset. Longer, 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 drop, reset. And the key to this one, the reason it's nice and I like it in there is like that group beating. Like you just sort of take a step back. Just like when I had you guys look at you were looking at this the other day. If you go 1, 2, go 2 more down, and you look at this EKG. Just trust your gut. Does this look good or not good?
Bad.
Right, your gut tells you that there's a freaking problem, right? You don't have to know what it is. Your gut tells you this is not a good, you gotta trust your gut sometimes. So your gut tells you this is just not good, right? This is wide and this is fast. And what do you notice about the QRS is they pretty much look all the monomorphic. They all pretty much look the same, right? So this is coming from some scar in the bottom of the heart. This is pretty classic ventricular tachycardia. It's fast. The QRS is wide because it's coming from the bottom of the heart. But you guys don't have to be cardiologists to look at this and go like, eesh, this does not look. Your gut tells you this does not look good, right? And I think the one after it looks even worse, right? You don't have to be a cardiologist to know this is probably not a good situation, right? So this one is the other example. This is, everyone agrees this is sort of wide and ugly and irregular. This is what we would call polymorphic ventricular tachycardia. And if you notice, what do you notice about the size of the QRSs? Well, they're big, and then they're another.
They're irregular.
So what's the classic term? Torsade. So this,
yes,
if you had a rhythm strip of this, just one lead going up and down, this you can see even on the bottom. They're big, and then they're small, and then they're big, and then they're small, and then they're big. So this is pretty classic torsades. This is ugly. This is
what
like
you don't want when you have a prolonged QT.
Yeah, very good. So you were in here last time, we talked about that. Prolonged QT interval, and that's good because someone brought up the COVID meds tend to be QT prolonging. This is terrible electrolyte abnormalities, like the alcoholics come in with this all the time because the potassium's like nothing and the magnesium's nothing, and they have terrible electrolyte abnormalities. When we keep people here, you guys don't see this because it's not your service. Like we bring people in for the fancy meds like Sotalol, amiodarone, all these meds that you guys would not and should not feel comfortable using. But there's a reason we keep them in the hospital for 72 hours to start them, is because they can prolong the QT interval, and if someone was at home sleeping, this is what it could do.
Yeah.
So that's why we have to put them in the hospital on central telemetry for the first 72 hours to make sure this ain't gonna happen before, and that we're doing EKGs constantly while they're here to check their QT interval, because this is what they're at risk for.
Are all the antiarrhythmics QT prolonging, or just some of them?
Some of them. So the ones that we, Sotalol, the class 3, Sotalol and amiodarone are the 2 classic ones that prolong the QT interval.
So those are the ones we should keep an eye on with these COVID guys.
Yep, so those are the ones that are, yeah. And so the treatment for acute torsades is what? Magnesium, no matter what the cause is. The magnesium will settle, it's crazy, it'll settle down like, yeah, now you might have to give mag again 20 minutes later, but no one ever died of hypermagnesia. Like, you just give it until you can reverse the process. More of a caveat than anything you guys would need to know. Don't forget, the longer the heart has to relax, the longer the QT interval is. So when the people that have bradycardia tend to have longer QT intervals. And we think that an extra beat that hits during that, you always hear about the R on T type thing, something that hits while the heart is repolarizing is gonna make you more likely to go into these. So if someone keeps having torsades, and it's because their QT is so long, one of the ways to do it is to try to shorten the QT interval, and one of the ways to shorten the QT interval is to speed up the heart. So we will sometimes empirically, even though they're not bradycardic, we will put them on dopamine, or sometimes we even put a pacer in and just pace the heart at 110 beats per minute to keep the QT short until the medicine or the electrolytes can get corrected and it stretches back down. So if you speed the heart up, the QT interval gets shorter inherently because the heart's working faster. So occasionally, I've had to do it once here where We had an alcoholic who took amiodarone. It was like the worst combination ever. He was luckily he had an ICD, so he had a pacemaker in place. He must have gotten shocked like 37 times in like 24 hours. I mean, it just kept going. And amiodarone is an extremely long-acting drug. So if I was on amiodarone today and I stopped it, it would probably be in my system for the next like 21 days. So you couple that with a guy who's so magnesium and potassium depleted that it takes a week for these alcoholics to get filled back up. So what we did was we took his pacemaker and just paced him at like 115. You know, he felt like his heart was racing, but it was better than getting shocked. He took that. He took that.
You're concerned for ischemia with that?
Well, in certain people, yeah, but it's better than that. I mean,
Yeah.
getting shocked is
So
no
is
fun.
polymorphic and torsades the same thing?
Pretty close.
Torsades
They're close.
Just a type of polymorphic.
Essentially, yeah. So torsades would be more of a prolonged. Yes, they would go together. I would
Those
say.
are interchangeable terms.
Pretty much. Yep.
Okay.
The next one, I hope everyone can recognize that because that's a problem. This is not compatible with life. You will not have a person talking to you with this. This needs CPR and emergent. This is ventricular fibrillation. And then the last one I just want to show you guys is the one at the end. So this would be the, like, God forbid, the last thing you guys would ever have to be dealing with.
That's the elevation and.
Right, so the first thing, so that's still the last thing you get to. You always want to try to go through your system. So taking away what's on the end of the strip, like V1, V2, it's a narrow complex QRS, right? There's P waves, so at least from a rhythm standpoint, they look like they're in sinus rhythm, right? If you didn't look at V4, V5, V6, you wouldn't really think there's anything wrong here. But then you get to, all right, they're in a normal rhythm, the electricity seems okay, but what do we notice in V3, V4, V5, V6? Those are tombstones, right?
Yep.
So that ST segment, if someone has taken it and pulled it up, this is a medical emergency. So this is someone that has this goes to we don't even see them here anymore because they ship them straight to a cath lab somewhere else. We used to sort of putz around with them here. This is someone that needs attention like ASAP. This is someone you do not worry about calling. This is someone where I'll be like, I'll do this, please call, the helicopter people as I'm talking to get someone to accept them. These people are going. And I can talk to you guys about that a little bit more at another point, the whole pathophysiology of it. But I just like you guys to look at this one because this, God forbid you see this is not something you're gonna, this is not something to sleep
So we have a cath
on.
lab here, but nothing to do
With
with interventional
interventions,
cardiology.
correct.
So, like these guys, like in the context of our new little ICU project we're doing here with demented patients, people having heart attacks aren't gonna tell you they have chest pain. So are you only kind of knowing that if they're having like hypotension or?
That's a good point. So I would, luckily, for whatever reason, nature's kind to us sometimes. It's very rare for a sick person that has what these guys have here to develop this. Usually if they're gonna have ischemia, it'll be ST depression. It'll be more like multifocal or subendocardial. Again, don't forget, all coronary ischemia or all heart attack is somewhere along the way, the heart muscle's not getting the oxygen that it needs. Now, in this situation, when someone has ST elevations, what happens is a cholesterol plaque inside one of the coronary arteries, we say it ruptures. It just sort of breaks open, and then your body sends a blood clot there. So anything distal to that area is not getting blood anymore, and your EKG starts to look like this. This is classically the guy that goes out to shovel snow, who's out of shape, and all of a sudden goes like this, or the woman who's at the funeral, and all of a sudden, this is an acute plaque rupture where the cholesterol breaks open inside an artery. The body says there's a hole in an artery, let me send a blood clot there, and then go, uh-oh, I just clogged off an artery, and this is what I see. The heart can also lose blood flow for other reasons. We showed the SVT, it's just not, it's working too fast. In sepsis and what these patients have, and in the ICU in general, there's so much inflammation, there's so much of these cytokines and the inflammation that the blockage is more like the capillary level, like the epicardial. If you did a cardiac cath on these people, it'll look fine. We're seeing the big arteries, but when it starts diving into the muscle and breaking down into like the arterioles and those capillaries just get clogged up with the same shit that's clogging up their lung, and then the oxygen can't exchange into the heart muscle, and that's why they get ST depression or positive troponins. It's not because they all of a sudden ruptured a big plaque in their coronary artery. It's just they have such screwed up hemodynamics and screwed up, sepsis and all that stuff. It clogs up capillaries everywhere. That's why they have kidney failure. That's why that's why it's multi-system stuff. It's not good for the kidneys. It's not good for the brain. It's not good for the lungs, and the heart gets caught up also because it's just impaired oxygen exchange at like the capillary level. But the heart muscle doesn't care. It doesn't care why it's not getting oxygen. It just knows it's not getting oxygen. So luckily, it'd be very rare for you guys to someone to have this on telemetry, but yeah, if they're vented, you'd have to have like a very astute nurse be like, something looks funny on their telemetry.
Yeah, so I mean, do you think it's fair to say, as a whole, in critically ill patients on vents, that people are probably having small non-STEMIs that we never know about unless they're symptomatic to show us something to look for it?
Yeah, I mean, I would say, yeah, I mean, trust me, we do the consults all the time. The first, why the hell did you draw the troponin? I mean, that's out of my mouth twice a week now. They're like, why'd you draw the troponin? Well, I don't know, well, he was sick. So, yes. So there's probably people, if they're not drawing them, but is it changing anything you would do clinically? Not really, right? The answer still make them, try to make them better.
Yeah.
So that's why. So I'm more of a big fan of only doing testing if it's gonna change what we do. You know what I mean?
Well, we as the non-experts though, it wouldn't be wrong actually for us to go down that avenue if we felt like.
Oh, if you
it
ever
might
think
be
something's
needed.
wrong. Yeah, and
Right,
like I
yeah.
said, people are gonna support you guys. It takes, with Epic and Tired, like, just, can you look at this? I mean,
Yeah.
don't be afraid to ask someone. It takes 2 seconds to look at an EKG.
Okay.
I mean, and I told you guys last time, as much as you guys have to be comfortable with ACLS protocols, the first room is still, you don't wanna be over aggressive, like, do no harm, like, all right, I gotta trust what I'm looking at here. And the thing is, don't forget, in every one of those ACLS protocols, that's really what you guys are doing, bradycardia with a pulse, tachycardia with a pulse. Both those things say expert consultation. They're right in there for a reason. You don't have to be a hero. Sometimes you don't have time and you have to be. But if you have the time where you say, all right, it's narrow, complex, it's fast, but their blood pressure's okay, they're mentating okay, let me take a step back, get a 12 lead, let me see, all right, do I need to talk to some, as opposed to running in there and doing something that you regret 20 minutes later. No one should be faulted, especially given what you guys gotten thrown there, should not be faulting you guys for asking questions. If you're not asking questions is when you're dangerous. So we don't, we say that when we're training residents, like, the ones that say they got it are the ones you gotta watch out for. Like, you should be asking
We know.
questions.
Be feared.
Yeah, no, I mean, we all went through our training. You always had new people starting underneath you. The second week intern that says, I don't need you, I got it, that's the guy you gotta be petrified of. It's the people that wanna ask and know what's going on and that kind of thing. But that's why I try to have you guys, all right, just take a step back. Is it narrow? Is it wide? Is it regular? Is it irregular? And I didn't say this today, but I said this last time, it sounds stupid. Symptomatic is different than unstable. I know that sounds stupid when you say it out loud. A lady with a heart rate of 150 and AFib who has some palpitations, if her blood pressure is 130 and she's talking to you and she's not having chest pain and she's making good urine, is she symptomatic? Yes. Is she gonna die in the next 2 minutes? No. You have time to treat her and figure it out. If a lady has this and her pressure is 80 and she's not talking and she's sweating then she's unstable. Unfortunately, you gotta put your nickel down and act, but just because they're symptomatic doesn't mean they're unstable. You have time to treat symptomatic people. The ones you don't have time to treat are the unstable people. And I know it sounds stupid, well, symptomatic, whatever, but symptomatic is different than unstable, okay? You don't have to do anything overly aggressive in someone that's symptomatic, all right? So, that's that. So if you guys want, I mean, you guys might be EKG'd out. If you guys, I sent Tori these are a couple other ones to practice. I don't even probably have to go through these with you. I think you guys will probably be okay. If you wanted to, what I can do even, Tori, is I can write down the answers and I'll just email them a copy
Okay.
with the answers written down. I put together a brief talk on AFib, like a PowerPoint thing,
Okay.
because you said that's something you guys see a lot also.
Yeah.
It will not be a whole thing. What's your guys' schedule? Today's what,
I'll
Wednesday?
stop recording.